episode under the aegis of Mumbai Hematology Group. And today we have two interesting academic presentations. The first one is on novel therapies in multiple myeloma and sequencing strategies, and the second one is on ETP ALL. Probably this is one of the longest running academic web series in the field of hematology every Saturday and Sundays. And all this has been possible courtesy MHG and our program director, none other than Professor Dr. M.B. Agrawal, whom you see on the screen, a teacher of teachers, an institution in himself. No wonder that apart from the great clinician and hematologist he is, we also learn various accolades of life. Sir, thank you for being there and a warm welcome to you. May I request you to take it forward from here?
Thank you, Dr. Manoj, for those kind words. Good evening to one and all. So today, we are extremely fortunate to have two very young, dynamic hematologists from two parts of the world speaking to us during this webinar. So first, we have Dr. Fahima Hassan from Prayagraj, and this will be followed by Dr. Deepanjan Haldar from UK. Dr. Fahima is going to speak to us on novel therapies in multiple myeloma and, more importantly, the sequencing strategies. And I'm absolutely excited to listen to her thoughts about the sequencing strategies. These twin lectures are brought to you by Mumbai Hematology Group, supported by INTAS and J&J, and managed by Perfect Square. I'm grateful to the team INTAS and J&J, Yash Kalpesh and team Perfect Square, Executive Committee of Mumbai Hematology Group, and of course, both our guest speakers, Dr. Fahima and Dr. Deepanjan. All our discussants were themselves eminent hematologists and medical oncologists, and new participants for sparing your Thursday evenings. The flavor of next Thursday. This time from AIMS Delhi, we have Dr. Ranjit Kumar Sahu, who is going to speak to us on CML, but it's not just CML, it's CML in India. And he's going to speak about his experience and the future directions. In 2026, because as you know, the management of mantle cell lymphoma is totally revolutionized. Few words about Dr. Fahima. She is Assistant Professor, Department of Hematology, United Institute of Medical Sciences, Prayagraj. She completed her DM in Clinical Hematology from the prestigious SGPGI Lucknow way back in 2021, and later on she served as a faculty there until 2023. She has a deep passion for both clinical and malignant hematology. She's actively involved in clinical practice, teaching, and research. She has won multiple national quizzes, best oral and best poster presentations at numerous renowned hematology conferences. She has co-authored several research publications in peer-reviewed journals. She is an enthusiastic educator and advocate of hematology awareness. She actively engages in social media outreach, workshops, conferences, and medical camps to improve public and professional understanding of hematological disorders. And as was mentioned, she's going to speak to us about novel therapies and sequencing strategies in multiple myeloma. So I stop here and hand over the platform to her.
Good evening, everyone. Thank you, sir, for the very lovely introduction, and I'm, of course, very honored and grateful to you for the opportunity. Today evening, we are going to talk about something very close to my heart and which always keeps me on the toes. As I was saying earlier, this year alone, I have given two talks on novel therapies in multiple myeloma, and I had to update my slides at least 20 to 25% with the recent changes. So that is how dynamic myeloma treatment is. So now let's talk about how this disease therapy has evolved over the years. In the 19th century, we were treating the patients with rhubarb, orange peel, and heavy metals. And then came the era of alkylating agents, and then we had our targeted agents, and now we are in the era of immunotherapy. But even in the era of immunotherapy, we have major unmet needs in myeloma that makes us hunt for even better therapies. And what are they? They are the patients with very high risk disease, like extramedullary disease, and patients with high risk disease. The problem is that they have extensive intratumoral heterogeneity. We also have something called spatial heterogeneity in patients with extramedullary disease, where every site of the myeloma tumor behaves differently and the genetic makeup is very different. And myeloma is a disease of elderly. We all know that. Even though us Indians have a high percentage of young myeloma patients, with age, there's a frailty spiral. So we'll have to make sure that the novel drugs are also catered to the elderly population. And right now, with quads coming up, friends, 70% of our newly diagnosed myelomas, at least in my practice, go for quad-based induction. So once they are exposed to an anti-CD38 molecule, the first relapse, that's the second line of therapy, the overall response rates drops to 58%, then to 45 with the subsequent, and almost 30% with the subsequent therapy. So we have two trials proving this, the Mammoth trial and the Locomotion trial, which are both retrospective for with Mammoth and prospective with Locomotion. The response rates are very grim at 30%, and the progression-free survival is less than 6 months. So this is a major unmet need. And the other is not only frailty, the tumor is also intelligent, it becomes resistant, and the patients become intolerant to the major targets. So, what have we done and how are we improving on the immunotherapy is what we are going to see next. So, from 2015 to 2025, the last decade has been all about the immunotherapies. I'll not call these 2015 agents new, but they are the oldest, newest agents, and we have the latest update. Approval for belantamab and linvoseltamab last year. So this is where we are currently. And in immunotherapy, we have a T cell revolution. And all these response rates are in relapsed refractory myeloma. All the drugs we are currently using were first introduced in relapsed and refractory myeloma. Can you see the overall response rates, which was less than 30% to all the previous drugs, including Dara and isatuximab? And with the T cell engagers and the T cell redirecting therapies, which are the CART and the bispecifics, the response rates is as high as 98% with cilta-cel, with the bispecifics closing up to the CAR T cells. So we can call this a T cell revolution in the treatment of relapsed refractory myeloma. So where we are headed is like every drug in multiple myeloma, initially introduced or approved in refractory cases, then it moves into earlier stage, into earlier relapse. We are seeing it with CAR Ts and the bispecifics. Not only are they moving into the earlier relapse, they're also moving into the frontline settings. The trials are on the way, and even in smoldering multiple myeloma. So this is where we are. I have set the stage for what we are going to talk about, and this is how our roadmap ahead is going to be. We are going to talk about four classes of drugs. Our T cell engagers, which is very easily available in our country. Then we are going to talk about the CAR T, which will make way shortly. Then we'll talk about the antibody drug conjugates. And then we'll talk about a very interesting groups or the advanced type of IMIDs, which we are currently use the cell mods. And then we will go to the important and the interesting part of our talk, that is the sequencing strategies. So let's go. First one is T cell engagers or your bispecifics. I purposely did not call it bispecifics because we have trispecifics right now. So these are the targets of our T cell engagers in myeloma. Multiple membranous targets from BCMA to CD138 to CD38, GPRC5D, APRIL, SLAM F7, CD19, n number of targets. But we are going to talk about three plasma cell membrane targets, which is our BCMA, the most abundantly utilized target for our immunotherapy. Then we are going to talk about GPRC5D, FCRL5. We are going to use 2 to 3 minutes to discuss about these because these are the basic of ADCs, CARs, and our T cell engagers. So, as we can see, BCMA, what is the biological advantage? It's preferentially expressed in mature B lineage cells, and it is very central to the plasma cell proliferation via the MEC, PI3K, NF kappa beta pathways. The problem with it is, as you can see, compared to the others, it is a single transection through the cell membrane, and it is liable to be shed into the plasma via gamma secretase. So there's a shedding vulnerability. And how do the tumor cells escape or develop resistance? It's by decoy saturation. Once a gamma secretase cuts the membrane target, it goes into the plasma, and your targeted agents are not going to act on your plasma cells. And there is also mutation in TNFRS17 gene, which can lead to loss of this BCMA. So these are the problems with BCMA. And next we come to our GPRC5D, the new kid on the block. This, on contrast to BCMA, it's a 7-pass fortress. I would like to show you the previous image where we can see it goes through the membrane 7 times. So it is not easy to be shed into the plasma. So this is the synaptic advantage of GPRC5D. And next, the newest kid, not yet approved, but very exciting data. It is a FcRL15, which is an immunoglobulin-like receptor that naturally represses B cell receptor signaling. It is highly expressed in malignant plasma cells. The one unique thing about this is more expressed in high-risk myeloma with 1Q gains. So now, just trying to compare all these three. So all of them are present in malignant plasma cells, with BCMA being present in non-malignant plasma cells also. GPRC5D, apart from plasma cells, it's also present in skin, hair follicles, and eccrine glands, and therefore has their separate set of side effects. And as I said, FcRL5 has been amplified in 1Q21 disease. So the primary signature toxicities of BCMA is infection because of severe hypogammaglobulinemia. Of GPRC5D targeting agents is going to be dysgeusia, nail shedding, skin rash, and FcRL5 is CRS. So let's dive further into it. So what are the current bispecific antibodies in myeloma? We have 4 drugs which are FDA approved. The first one being teclistamab, followed immediately by elranatamab, talquetamab, and linvoseltamab. And we have the two kits, cevostamab, which is an FcRH5 BiTE, and we also have a second generation BiTE, which is etentamig, which is again BCMA targeted. So how does this work? We all very well know it brings the T cells and the BCMA antigen on the myeloma cell, it binds to it and it brings them together, and it causes cytokine secretion and cell death via granzyme and perforin. So, to make things short, we have Tecli, Elra, Linvo, and Talquetamab, and this is a side-by-side comparison. Except linvoseltamab, everything is subcutaneous. All of them have step-up dosing to mitigate our CRS risk, and except elranatamab and linvoseltamab, Tecli and Talki are weight-based, whereas elranatamab and linvoseltamab have flat dosing. CRS is seen with both Tecli and Talki, which we have the maximum experience with. Elra and Linvo has slightly lesser risk of CRS. ICANS, similar profile. The one good thing about talquetamab, which I would want to highlight, is the one thing which is really, really terrifying when we are giving T cell engagers are neutropenia risk and the risk of infection. So it is almost half as that of teclistamab. Neutropenia and infection is half that of teclistamab, which gives an edge for talquetamab. But of course, as I previously said, talquetamab comes with its own set of side effects. So this is a step-up dosing for all the BiTEs which are currently available. And I previously said you the one thing which is most terrifying is not the CRS, but the infection risk. How do we mitigate the bispecific therapies infection risk? There are 3 causes for bispecific therapies infection risk. It is more common with BCMA because our non-malignant plasma cells are also going to be affected. So the patient related is that the treatment target leads to significant hypogammaglobulinemia, right? So the number one thing is the hypogammaglobulinemia in the patient. The other thing is a myeloma related. It causes T cell dysfunction and exhaustion because BiTE is a continuous therapy. So it causes a lot of T cell dysfunction and exhaustion and activation of immunosuppressive Tregs. And myeloma related, again, the higher the tumor burden, the higher the CRS risk, and related concomitants, immunosuppressive medications, which we are going to give for the CRS, to mitigate the CRS. And again, the third cause of the infection risk is the treatment related, because continuous therapy by design in most protocols, and this causes a significant treatment related T cell dysfunction, B cell dysfunction, and subsequent infection risk as well. So how do we mitigate the infection in patients receiving bispecific antibody? We have to use antiviral prophylaxis, which we are already using in all our myelomas. We have to screen for HBV reactivation. We have to administer monthly IVIG. The first Tecli I used was in 2022. I lost a patient to infection. Right now, none of my Tecli patients are having any infection risk as of now, touch wood. Because even before giving the teclistamab, I prime the patients with giving with prophylactic IVIG, and that is the recommendation currently. And we should not hold by from giving colony stimulating factors, and we do not use aspergillus prophylaxis, and we have to use PJP prophylaxis, and we have to make sure they are all vaccinated. So this is the consensus recommendation for managing infections in patients with bispecific antibody therapy. Talquetamab, I previously said you, it has its own, apart from infection rates are way less with talquetamab, half of that of teclistamab and even Eldra if you compare. The toxicity of talquetamab, because of its presence in the nail and the skin, is oral toxicity, the skin toxicity, and the nail toxicity. So how do you manage that? It's with salivary stimulants for oral toxicity, emollients for skin, and nail soaks and strengtheners for the nail toxicity. And we can consider dose modification if these are severe and leads to severe loss of weight in the patients. So now what is new in the block? We have been using Tecli very often and Talki in the rare cases. So we have Cevostamab, which I previously said you also. It's a very interesting molecule. You know why? Because it is more abundant. This marker is more abundant in the high risk myelomas. And the one thing which we are so afraid of it, because of the high risk myelomas, the tumor burden is high, the risk of CRS is also high. The other interesting molecule is etentamig, which is a second generation BCMA BITE, composed of high avidity, bivalent BCMA binding domain, and a low affinity CD3 binding. So what it does is, because of the low affinity CD3 binding, you have low CRS, and it has a silenced FC tail, which lets its administration every month, 4 weekly and 8 weekly, making the life of the patients way better. So this is what we are developing on in the bispecifics. And we also have, this is why I didn't call it bispecifics in the beginning, as T cell engagers was a term I used, because of this interesting molecule, ramantamig. It is a potential first-in-class tri-specific antibody. So it uses both BCMA and it also targets GPRC5D. Very exciting data with almost 100% MRD negativity, but of course with its own risk of CRS because of potent cell killing and the cytokine storm. So apart from the initial bispecifics we were talking about, bispecifics are also entering our myeloma therapy forum with combination. The classic example being the March 6 FDA approval of Tecli plus Dara after first prior line. As we previously discussed, things are moving from relapse refractory to earlier relapses. So it is very interesting. So I wanted to show you the progression-free survival of the Majestic 3 trial based on which this FDA approval was done. 83.4 versus Dara PVD of 30%. That is 3 times better PFS. At 3 years, it's really impressive. But I also want to show you this curve. If you see in the first 10 months, can you see, this is the OS curve. Can you see that the Tecli Dara and the Dara PD is crossing over? This is because of the infection risk. Patients are dying because of infection. So that is one thing which is really, really terrifying with use of bispecifics that we'll have to mitigate with strong prophylaxis and IVIG. So then we have the linker MM2 and the where linvoseltamab is being given with carfilzomib in relapsed refractory myeloma. Very nice early phase results. The same with talquetamab, dara, and pomalidomide in TRIM2. Redirect TT. Very interesting data where we are giving 2 bites together. And this is one early phase trial which has allowed extramedullary disease. The concept being extramedullary disease has multiple clonal heterogeneity in different places. And so targeting 2 antigens would give a better result. So yes, we are very impressed with this early trial data. And we have this first study of tri-specific antibody, which we previously discussed. So now we'll move on to the CAR T cells. Not our forte, we'll not spend much time here, but we'll see what are the new things in CAR-T arena. We are well aware of the ID cell, Silter cell. We also have a Chinese CT103, which is awaiting approval in the America. It's already approved at Singapore as well. And we have an academic card called ARI 0002H, which is academically funded, and the research work is completely academic funded for this. And we have a dual card, BCMA and CD19. And the other interesting thing about AZD0120, which is a dual card, is it's a fast card. That is, the manufacturing of the CAR-T is not going to take 6 to 8 weeks, but rather 2 to 3 days. So this is a newer technology where the cards are synthesized very early, making it easier for the patients and of course the physician. And we have a novel synthetic card called anitocell, and we have GPRC 5D targeted CAR-T as well. So we can see the overall response rates of all these new cards. 81 with the earliest CAR-T with 100% in our dual fast CAR. Very exciting data ahead. And again, 100% with the GPRC 5D CAR-T. So we also know that the overall response rate and the complete response rates are improving as we go on with the newer cards. So this is the classic data of Cartitude, which really was impressive. What we saw was that at 5 years, the progression-free survival curve of Cartitude flattened. So is this a cure? Are we looking at cure in these patients at 5 years who are alive at 5 years? It patients who have received cilta-cel. So now the aim is to make sure this goes way up, and maybe we can say that these percentage of patients with myeloma are cured. Very exciting data for myeloma patients ahead. So the plan is to get there. So we know the CAR T cell therapy toxicities, acute toxicities, CRS, cytopenias, immune effector cell associated neurotoxicity, and non-immune neurotoxicity. We know how to manage the acute toxicities. I mean, from the lectures in India, we don't have the CAR Ts for BCMAs as of now, but we are well aware of what is happening. The thing about CAR T cell, which I am really concerned about, is the delayed toxicities are the B cell aplasia, hypogamma globinemia, Parkinson's of 5%, secondary malignancies of 5%, which becomes very difficult when we are going to explain the risks to the patients before administering or counseling them for CAR T. And we know how to manage the delayed toxicities, but we really don't know how to manage this non-immune neurotoxicities, which is the Parkinson's disease specifically, and also cerebellar ataxia. So now what is most exciting even in the CAR T phenomena is this in my car. Very exciting, especially I think for the Indian population. This is going on in Australia, where you don't have all these, you collect, you do the pheresis, then you do the CAR T engineering, then you let it expand. In KLN 101, which is by Calonia, what they do is they have this lentiviral vector. It is directly infused into the patient. So the entire CAR-T process is done inside the patient, which eliminates our lymphodepletion. It greatly simplifies the logistics, which is a major part even for the Westerners to get the CAR-Ts. And there is no ex vivo culture that will increase the T cell, that might impair the T cell witness. And this will also reduce the cost of goods and manufacturing. So exciting data ahead in the CAR-T spectrum. So this is what the KLN 10110 is. Very exciting data. And they have data for 18 patients right now. But this is with the, I think, this is ASH 2025, where they showed 6 patients, all of them being MRD negative. The longest duration is 6 months, and they are MRD negative. All the patients who received this modified LVV generating anti-BCMA CAR-T. So now we have seen two kinds of T cell redirecting therapies, the bispecifics and the CAR-Ts. So I want us, even though we don't have, in an ideal world, we have to give these options to the patients, right? So we'll have to compare the toxicities also of both. So we have ide-cel, cilta-cel, tecli, elra, talquetamab, and linvoseltamab. The CRS rates, as we are already aware, and we also know how to mitigate the CRS with steroids and prophylactic tocilizumab. We also have this NINT, or the Parkinsonism, we have previously discussed, but these are way lesser. But what is more concerning is the grade 5 infection mortality. That is death. The patient died because of death. If you compare all these T cell redirecting therapies, the Tecli, which we are using the most, has 13% incidence of infection related death. This is just to highlight how cautious, especially in a country like ours, we should be before using bispecifics. And talquetamab, on the other hand, why I'm so excited to have talquetamab is that it is 1%. It's lesser than our CAR T cells. So yes, we are eagerly awaiting talquetamab. So third drug point we are going to go with antibody drug conjugates. So we know the same thing, old wine in a new bottle. It was previously approved and then it was withdrawn because against pomalidomide, it did not have any superiority. It was reintroduced in 2025 based on DREAM9 trial. It is an antibody drug conjugate, belantamab mafodotin, not a T cell redirecting therapy. It's an ADC. What actually it does, it's a monoclonal antibody with a linker which has a cytotoxic drug payload. It goes and attaches to the multiple myeloma cells, and the cytotoxic therapy enters into the multiple myeloma cell, causing the myeloma death. Apart from that, it also has a immunogenic cell death and ADCC mechanism as well. So this is what belamaf is, which we have been already using in other diseases like brentuximab vedotin and Hodgkin's lymphoma. So this was a DREAM7 trial based on which it was approved. It was compared with Dara-VD, and it did show a good progression-free survival compared to it. It is 63 versus 37%. So DREAM7 safety, we all know even in 2020 when it was brought into the scene, we all know that 90% of patients who took belantamab mafodotin had keratopathy. So that is one thing which actually is terrifying when it comes to use of belamaf. But nowadays we have learned, just like how we evolved with teclistamab and we got to know what are the supplements and the prophylaxis we'll have to give, how we'll have to give IVIG to mitigate the risk of infectious death. We have also learned with belantamab mafodotin, belamaf, and we know how to identify the eye toxicities and to reduce the grade 3, grade 4 adverse effects. So now we come to the small molecules, not not related to any cellular membrane target. The most exciting thing about this is supposed to be the fast and furious version of our lenalidomide and pomalidomide, the cell mods or the cereblon E3 ligase modulators. So we already are well averse with our classic IMID agents. These are the novel cell mods. Even before, the cereblon was discovered after we started using IMIDs in myeloma therapy. And then we discovered the cell mods. So we have two things which we are going to talk about, and semisdomide is also there, iberdomide and mezigdomide. So these are just better, fresher, younger, more superior versions of our lenalidomide and pomalidomide. So classic IMIDs exists as a mixture of SNR isomers, and when they bind to cereblon, the percentage of the configuration being closed actually translate into the efficacy of the drug. With len, the percentage closed is only 25%. With pom, it is 20. With iberdomide, it's 50. And with mezigdomide, it is 100%, thereby making mezigdomide as one of the most potent cell mods. So we can also see the anti-proliferative activity of the cell mod agents. Impressive data with mezigdomide, of course, impressive data with iberdomide. We were even impressed with pomalidomide. So now we know that in the relapsed refractory setting, iberdomide and mezigdomide are going to be really good agents to treat. But what is more important and more exciting about this cell mods is that it is associated with T cell activation. So we will be discussing in the further slides that how T cell exhaustion happens with our T cell redirecting therapies, that is our BiTEs and CAR T cells. So the major mechanism of failure of BiTEs is because of continuous therapy, your T cells become exhausted. Number one. And again, when we are going to give, after bispecific failure, if you're going to give a CAR T cells, the T cells are already exhausted, the collection is going to be difficult, and the efficacy of the CAR T is also going to be going down. So what we noticed with cell mods was that it improves T cell activation and NK cell proliferation. So this gave rise to the idea that maybe if we are using the cell mods in combination with the BiTEs or in combination with the CAR Ts, the efficacy of these drugs and the risk of T cell exhaustion will be minimized. So this is the data which we have later used or exploited to make the efficacy of the T cell redirecting therapies better. So it improves the efficacy of T cell immunotherapy. These are the images to show how mezigdomide enhances CAR T cell efficacy. So comparing iberdomide and mezigdomide, both are orally administered and they both demonstrate activity in heavily pretreated patients, and they are being studied in earlier lines also. But what is the difference is that mezigdomide has greater cereblon binding potency, thereby causing more significant cytopenias. And of course, because of the potency, there is subsequent downstream antimyeloma effects as well. So we have 1 to 2 minutes dedicated to cell modes also. So we have these four classes of drugs, which are the newer therapies in multiple myeloma, and then we move on to the sequencing strategies. We have the TEC, we have the ELRA, we have the LINVO, we have the TALVI, we have ID-cell, we have Cilta-cell. How and when to use? Majority are BCMA, how are we going to sequence? And we have this Belamaf also right now. Let's see. So consideration sequencing always is logistics. Now we cannot talk about ID cell and Silta cell. It's not yet available in the country. So that is one thing. Number two is a time. How much time the patient has. Does a patient's tumor load allow you for 8 weeks for manufacturing of the CAR T cells, unless and until you have access to fast CAR, which is now right now in early phase trials, and availability. As I previously said, we are not having access to the CARs. And then, of course, comes the budget. Even though CAR T cell one is one and done, it is a lot of money in the beginning. And again, leaving all those apart, we have three agents. Out of the four, we discussed three are BCMA, majorly BCMA targeting agents. So the CARs, the BiTEs, and the antibody drug conjugates are all fighting for the BCMA target. So how do we decide? So now we'll go one by one about with the available drugs. What happens when we give bispecifics before CAR T cell therapy? So this is the cohort C of CARTITUDE. When prior BCMA therapy was given in CARTITUDE 2, cohort C, Belamaf, the response rate is 62%. Do you remember the previous CARTITUDE data I showed you? It is 98%. The ORR is 98%. It comes to 62% if there's a prior Belamaf exposure. What happens if it's BiTE exposed? It falls even down, half of the response rates, 57% only after being exposed to bispecifics, that is teclistamab. What is the cause of this? There is multifactorial. The emergence of BCMA resistant tumor clones with prolonged anti-BCMA bispecific antibody. As I said, we still don't have the guidelines or the idea or the knowledge as of now to say when we can stop the bispecific therapy. So it's a continuous therapy, it's an ongoing therapy, so it goes on and on. Therefore, the emergence of BCMA resistant tumor clones obviously develop. And also there is mutations in the extracellular domain of the BCMA protein, which is a TNFR17, which causes biallelic loss of BCMA. So obviously the currently two approved CAR T cells, which are BCMA targeting, so they will not work. So this is the reason why when we are giving bispecific before CAR T, the response rate is very much minimal. But what about talquetamab? Talquetamab is an interesting molecule. We have a GPRC5D targeted bispecifics. It is not as bad and it is way better than with teclistamab. So with prior talquetamab, the overall response rate is around 77.8 if you're giving CAR Ts. So bispecific after CAR T, what happens if you are going to give bispecifics after CAR T? First, we have said what happens first, you have given bispecifics and then you are going to give CAR T cells. What we have learned is that the efficacy is markedly reduced. What happens if the patient received the CAR T first and now we are going to give the bispecifics? This is the cohort C of the Majestic trial. So if you see the overall response rate of bispecifics after prior CAR T is 52.5%. Not very, very bad. So yes, bispecifics can be entertained after CAR T cell therapy. It is not as bad as giving CAR T cells after bispecifics. So this is the ELRA data, which is again the same as that of the Majestic data. So BCMA targeting bispecific antibodies can induce responses in patients with prior BCMA CAR T exposure, but definitely they are inferior to those seen in patients who are BCMA naive. So how and what happens, as we previously discussed also, the mechanism of resistance to BCMA therapy, they are like three folds. It's because of the T cell features, because T cell expansion, persistence, T cell phenotype, and T cell fitness decreases after a prior T cell redirecting therapy. And the bone marrow microenvironment, there's a lot of inhibitory mechanisms which develop suppressive cells and inhibitory cytokines, which impair the actions of both the bispecifics and the CAR-Ts. And we have intratumor heterogeneity, which we are speaking from the very beginning. This is exactly the reason why we are developing, tri-specific T cell engagers or bispecific CAR-Ts, so that we can address the intratumor heterogeneity with multiple markers. So that is where the future is headed. And because we have multiple BCMA targeted therapies right now available, uh, and in an ideal world I'm talking about, and the CAR-Ts also, IMWG in 2025 came with sequencing recommendation. So the prior therapy and optimization, patients can proceed to T cell redirecting therapy with no concern if they are following treatment with PI, IMID, monoclonal antibody, or corticosteroid, which is our classic second line relapse patients. And when should we consider for CAR-T? Aim for a 2-week washout between the last dose of PI, IMID, or DARA, or isatuximab, and apheresis. Avoid high-dose alkylators and bendamustine, which we don't use, prior to T-cell redirecting therapy. When we are considering for CAR-T cell therapy, this is for T-cell engagers, 2-week washout. But when we are considering for CAR-T therapy in the near future, in a good India, we are going to definitely have CAR-Ts, maybe in a couple years. Aim for a 4-week washout from T cell engager and collect cells prior to T cell engager initiation. So this is a consideration. So if you consider the efficacy of the treatment, always pursue PCMA targeted T cell redirecting therapy ahead of an ADC. That is, consider a BiTE or a CAR-T cells ahead of giving a antibody drug conjugate, so that we preserve the BCMA antigen. Both BCMA and GPRC5D targeted immunotherapy are safe and active in patients with prior BCMA CAR-T. Why? Because, we have also data saying, for example, you have a bispecific you had given teclistamab. The resistance to teclistamab, assuming that it is because of mutation of that BCMA antigen, that mutation might not confer resistance to elranatamab. So if you give elranatamab, it can still work. So that is why both BCMA and GPRC5D targeted immunotherapy are safe and active in patients with prior BCMA targeted CAR-T as well. And also T cell engagers. We cannot absolutely say right now a patient who is prior exposed to teclistamab will not respond to elranatamab. And also for patients progressing on BCMA targeting T cell engagers, provided it's available, try to shift to a different mechanism of action like GPRC5D. And if a patient is having a heavy disease burden, always consider bridging therapy in patients with high disease burden or at risk of mortality in CAR-T manufacturing period. So the ideal bridging therapy will contain an agent that the patient is not resistant to with very low risk of infection. And prioritize T cell engagers over CAR-T therapy for faster access in patients with high disease burden. Time, if you don't have the time of 8 weeks to wait for CAR-T, go ahead with T cell engagers, is what IMWG recommended. So this is a sequencing recommendation. In an ideal world, if you have equal access for both all forms of anti-BCMA therapies, the first priority should be given to the BCMA targeted CAR, which is not with us. And the next would be T cell engagers, that is your bispecifics. And the next should be our BCMA targeted antibody drug conjugate, which is our belamaf. So CAR-T first, then your Tecli, Talki, Elra, and then you go with our belamaf. And this is the IMWG recommendation for holding therapy. Holding therapy is something you do before the pheresis for a CAR-T. So PI, IMID, and naked monoclonal antibodies are recommended. Do not go for BiTEs or alkylators as holding therapy. So there's a difference between holding therapy and bridging therapy. Bridging therapy is once your apheresis for CAR-T cell is done, what are the drugs we can give? We can give T cell engagers, we can give alkylators, we can give PI, IMIDs, and CD38 monoclonal antibody. Assuming that we have only BCMA targeted CAR-T in the pipeline, the T cell engager should be of a different target, that is talquetamab, GPRC5D targeting. So then we have a BCMA targeted CAR-T, and if the patient progresses after CAR-T, then we'll have to change the antigen for the further immunotherapies. We can give GPRC 5D targeted bites, or even we have GPRC 5D targeting CAR Ts. And if the patient has no access to our card, of course, BCMA targeted T cell engages until disease progression, like in our country right now. And if the disease progresses further on it, we'll have to go with a different antigen target like talquetamab, which will be available shortly. So this is the correct selecting BCMA targeted immunotherapy modalities based on the IMWG 2025 data. CAR-T preferred over T cell redirecting therapies, T cell engagers in patients who have rapidly progressing disease, who are unlikely to safely complete pheresis. Go ahead with the T cell engagers. When both options are available, T cell redirecting therapies should be preferred over our belamab, that is your bites or your CAR T cells. In patients who have prior BCMA exposure, if you have previously received either a ADC or a CAR T or a bispecific T cell engager, following prior BCMA directed CAR T cells, both BCMA directed and non BCMA directed immunotherapies remain potential treatment options. So, if a patient is relapsing after a CAR T, there's a difference in type of relapse. So, a patient post CAR T can relapse within 6 months, or the patient can relapse after 3 years. So, the resistance clone is going to be completely different for both. So, it has to be individualized. Say, for example, a patient is relapsing immediately after 6 months after CAR T, then BCMA directed immunotherapy may not be a very good option. We have to try to change the antigen. But say, for example, the patient is relapsing after 3 years, the story is completely different. Responses to subsequent BCMA target therapies may be less frequent and less durable compared with BCMA naive patients. We will also be able to counsel the patient that we are not going to look at 98% overall response rate as in BCMA unexposed patients. In patients progressing during or shortly after BCMA targeted T cell engagers, switching to always an alternative mechanism of action, which is a talquetamab currently approved, or we have the newer FcRL5 targeting T cell engagers that should be considered. So what is the current scenario? As we previously know, we are all well using teclistamab. Frequently, we have, I think, not mastered. We already know what to expect with teclistamab, how to prevent the infection-related deaths. We are already having, the Pfizer launched elranatamab. It's available. Talquetamab will be available shortly. Right now, we are importing from Singapore. We are going to get BCMA cards maybe by the end of this year or the next. Not the ideal world, but we are reaching there soon. So we are talking about MRD. That most novel thing in myeloma is targeting MRD negativity. But MRD negativity at one time point is not what we are talking about. We are talking about progression-free survival. Sustained MRD negativity is where we are headed, so that we can go from saying myeloma is an incurable disease and to the fact that myeloma can be cured in the near future. Thank you. So have I finished it on time, sir?
Absolutely. You left 15 minutes for us to bombard you with questions.
Sure, sir.
Thank you very much, first of all, for updating us. Beautiful talk. You prepared it extremely well, updated us with a lot of information. And a lot of people present over here who must be itching to ask you questions. And I'm also expecting some questions to come up from the audience in the chat box. Meanwhile, can I ask you one question?
Definitely, sir.
So if you have a patient who appeared to be standard risk myeloma, you treated in a standard way with the quad, etc., autologous transplant, maintenance was going on, and patient relapses with an extramedullary disease. What's your immediate approach in India at the moment?
So within how many months? So he was quad induction. He received quad induction.
2 years of maintenance.
2 years of maintenance with Dara and Len.
No,
So
no, only Len.
only. So Dara and Tekli, sir, based on Majestic 3.
Okay.
They did not use a EMD, but I did see a patient recently who received teclistamab for EMD, and he showed beautiful response. So based on that, my next go-to would be a Dara Tekli based treatment.
And what will be the role of radiotherapy in this situation?
Yes, if it's a skeletal EMD, yes. To reduce the bulk, I will definitely, so that it will also mitigate the CRS risks.
Okay. And any use of alkylating agents?
As of now, I don't use alkylators, sir. I don't.
Okay. Uh, The question coming up in the chat box from Anil Kumar Yadav. FCRL5, is it applicable for double deletion of 1P, because double deletion of 1P is a high risk versus 1Q gain amplification? The second is it applicable for TP53 deletion 2?
See, I'm not telling FCRL5 is only used in 1P gain or amplification. They just said that FCRL5's expression is very high in this subset. So any high risk disease definitely has a role. So irrespective of your TP53, I think FCRL5 is a very nice bispecific to be used in high risk myelomas. Another thing why I would lean towards FCRL5 targeting BiTE is that in TP53 mutation, it's coding by the chromosome 17. There is also loss of chromosome 16 in 30 to 40 percentage of patients, which also codes your BCMA. So your BCMA targeted therapies may not be a very good go-to in patients with concurrent TP53 mutations, mutated myelomas.
Thank you. If you have a late significant cytopenia following the bispecifics, what do you do with them?
So give growth factors, and I also try to delay the next dose of bispecifics until count recovery.
Okay. And what is your indication for giving IV gamma globulin with bispecifics?
No levels. Before giving bispecifics, irrespective of the IgG level, I always go ahead with prophylactic IVIG at 0.4 grams per kilogram body weight. And also majority of our myelomas are IgG myelomas, so it becomes very difficult to quantify our IgG. So I think I don't have any cutoff. Before beginning of IVIG, before beginning of giving bites, I give IVIG supplementation.
Right. Is there anything like an endpoint when you stop giving IVIG?
Along with that, I keep on monitoring the IVIG levels, and once in the follow-up, it becomes less than 400, I give them IVIG.
And when do you stop giving IVIG? I mean, say you're given it for a year.
It is as long as the patient is on T cell engagers, I continue. Right now, my longest follow-up with the with Techly has been 9 to 12 months, and I'm still regularly in every visit, like every 4 weeks, I check the IgG levels. And in the beginning, it was every 1 to 2 months. Now it's been 4 months. The patient's IgG levels have drastically improved, and that is where the newer researchers are also going. Now they are planning when to stop the bispecific T cell engagers. So the trials are going when to stop it so that we can stop the continuous therapy and the need for, and also stop the T cell from getting exhausted. So I found very interesting data on that, but because of the time limit, I could not put those slides.
You can tell us now when to stop.
No, that's what they are working on, sir. So now with newer data coming on, I think more than Majestic 3, Majestic 9 data is very relevant because we are going to use daratumumab upfront, right? And we have 65 to 70% response in these patients. And once it's MRD negativity, now the trials are that how much sustained MRD negativity, my last slide I was trying to say, there's sustained MRD negativity, maybe there becomes a time point when we can stop the T cell engager therapy. So then we'll know the patient is cured, just like what we saw in Cartitude trial, 35% at 5 years with no progression, completely cured. So that should be the aim for us.
Thank you. A relapsed myeloma has 1Q amplification and no 11-14 translocation. Is there any role of venetoclax?
Venetoclax, I would not completely rule out there is no role in patients without translocation 11 and 14. But for this specific subset you are asking about in gain 1Q or 1Q amplification, I'm not completely aware of the data.
What is your prophylaxis with the bispecifics?
Acyclovir, Septron, IVIG. I don't give any Flucon. I definitely give, and I vaccinate for COVID, influenza, and make sure pneumococcal vaccination is up to date.
No antibacterials?
No. I don't give antibacterials.
Okay. We have Dr. Babita question, asking you question. Babita?
Thank you very much, sir, for having me on this platform. And Dr. Fahima, thanks for very comprehensive and novel talk.
Thank you,
We
madam.
have discussed at length about the novel therapies in the multiple myeloma, and in fact, the T-cell engagers have kept us engaged for the full 40 minutes. And just you have rightly said that it is a disease of adulthood, multiple myeloma, but the significant pediatric population also gets affected by this. And my just spontaneous query is that the novel therapies which you have discussed, they have the same outcome as in the adulthood, or are the directly speaking, are there the effective studies happened in the same age, pediatric age population to have the strategic outcome of these novel therapies, Dr. Fahim?
Before Dr. Faima answers, what is the youngest age you have seen a myeloma patient in the pediatric age group?
So you are asking me?
I'm asking Dr. Babita. You talked about pediatric patients, no?
So around 18-20, we have seen some patients having the multiple myeloma.
Okay. Fine. Faima, you want to answer?
Yeah, ma'am, majority of the trials are taking only adult patients, 18 to 65, depending on various agents. But what I'm concerned is all the cases you're talking about should be actually primary plasma cell leukemia. That is the most common disease you'll have in that age. So they are all high risk, and definitely they need to be treated as intensive as an adult agent. But right now, we don't have a separate set of data for patients very young. We have to treat plasma cell leukemia different from that of myeloma. It is not going to be a standard VRD based regimen. So how, depending on how aggressive it is, how much cytoreduction we need. In the good old days, we were using VDT paste. Now I think Dara VRD is a reasonable way to go ahead, provided it's just in a plasma cell leukemia and there is no multiple EMDs, and then go ahead with immediate transplant is a way to go. More than even depending on the novel T cell engagers, get them MRD negative or at least, PR at least, and then go ahead with the melphalan based conditioning and an autologous transplant. I would even consider, based on the genetics, allogenic. If you've seen someone as young as 18, the youngest myeloma or even plasma cell leukemia I had seen was 25 years old female who presented with a intracranial mass. So I had never seen a myeloma or a plasma cell neoplasm younger than that. So what we did was we went ahead with Dara VRD and immediately transplanted her at 4th month.
Thank you. Ramesh, your question.
Thank you.
Good evening, sir. Faima ma'am, it was a wonderful talk as usual.
Thanks, Ramesh. Thank you.
So I have a couple of questions. First is, as we were discussing last time when we had a conversation over phone regarding a case, like what is the, do you have any cutoff for age above which you don't want to give Dara technique combination? Like the patient is like, say, for example, the patient is 72, more than 70. And the patient does not have any comorbidities. Patient is healthy, like well
I
built.
will not stop them from giving Daratecli. As a matter of fact, Majestic 3, majority of the patients were of the same age group. So, but then I would be very cautious with the infection-related mortality and my IVIG prophylaxis.
Any specific precautions you would do, like for
First
those
time
patients?
in-house, keep them for monitoring of CRS. I'm not very much fascinated by your Optal giving tocilizumab before Tecli. No, it is also immunosuppressive. I think in India, we should be more afraid of the infections because I have lost my first Tecli to infection. I'm very cautious. So first cycle, still the step-up dosing is done. I keep them in-house and then send them off on an OPD basis, the same routine prophylaxis. And in a 71-year-old, I also give levofloxacin just like how we give Dara VRD for 2 to 3 months as well. Provided we have completely ruled out existing tuberculosis, I give levofloxacin also in a 70-year-old age set, Ramesh. I don't keep age as a bar for giving Daratecli. It has been smooth. I have 2 patients currently above 70 on Darateclistamab. They have been doing well.
Okay. So the second question is, like now that MSmart 4.0 has got, does not give more weightage on 1Q gain, like 1Q gain has to be there along with other high risk mutations.
Yes.
Right. So, but we do see some patients, classically we thought like 1Q gain is a very high risk and upfront we give with the quadruplet regimen. Now that has been removed, like 1Q gain alone is there. Like, could you treat those patients upfront with only a triplet therapy or a
I
quadruplet
go
with?
for every patient who are agreeing for quadruplet based induction, whether it's standard risk or high risk, irrespective of that. Affordability comes next. I'm not in an institute anymore. I'm a community hematologist. So better outcome is what I'm after. First, quadruplets, show them the data and explain them. If not, only I go for VRD, irrespective of standard or high risk. Ramesh.
Even if the patient has got trisomies, like the
I do.
classical
Yes,
standard.
yes, absolutely.
Can I just add? Ramesh, I think the only place for triplet will be, of course, the finance that we forget about. We won't discuss finance. Will be person who has a contraindication for Velcade-based therapy, bortezomib. So sometimes you have people whom you are not comfortable giving bortezomib, then you just give Dara, Len, and Dexa. Otherwise, in 2026, it will be difficult to justify anything less than the quad.
Okay.
We're not
Fine,
discussing the finance part of it. That part.
Fine, sir. Fine, sir. Thank you.
When you open the chapter of levofloxacin,
Yes.
you will give it only for people above 70. In India, you don't think it's worth giving to everybody?
So all inductions, Dara, VRD, I give for the first 3 months.
You give it.
I give it.
Fair enough. That's what I also do. I think it's not worth taking a risk. Any other question? We have a minute or two. Oh, in fact, we have 4 minutes.
I have one question for
Please, Amit, go ahead.
for patient who has relapsed from the same note what Dr. Agarwal sir asked the question to you, who relapsed on extramedullary disease, a standard risk, relapsing as an extramedullary disease within 1 year. Now you've got three options out of CAR T cell therapy. Second is Dara Tech, and third is Tech, as well as the second bispecific antibody which has come, that is teclistamab and talquetamab. So Tectal, Dara Tech, and CAR T. Out of these three, what should be the sequence? Or first which, second which, third which?
CAR T with such a bulky disease is not something we are very concerned about. We have beautiful data for Talki and Tekli, but it has a lot of infectious risk. Even with them, the mortality was pretty high, sir. Redirect TT is a trial. So I think with my own experience, I've seen Dara Tekli. I will go ahead with Dara Tekli.
So Majestic Dara Tech, not
Yes,
Tectal.
Majestic free. Tectal available, yes. We'll have to be very cautious about the infectious rates. Let the phase 3 data come, then I'll be more comfortable. But with the phase 3 data of Majestic 3, I'm pretty convinced.
Can I just add?
Yes.
So, Amit, if there is a one large extramedullary disease, wherever it is, I will use radiation, because these are extremely sensitive to radiation, and it's better to get rid of this. In Indian circumstances, cost is always an important factor, and this becomes the cheapest modality of treatment. Second, from the same token, alkylating agents work here. So something like, the PACE part of VDT PACE, those drugs are effective. So you can get some utility of those drugs as well. And then, yes, you have all these modern gadgets, whatever is available to you. At the moment, we have only one bispecific easily available to us. So you use that as and when CAR T becomes available and the dual bispecifics become available, you can use them. This is a bad disease. So you have to think of whatever best available. One last question can I ask? You have one more question, Amit?
Yeah, and for suppose after giving Dara Tech, your patient goes into remission for extramedullary disease. Is there any role of tandem transplant for these patients, or only one transplant is fair enough?
So you said it's a standard risk myeloma, but he relapsed in 1 year, so it becomes functional high risk. Yes, definitely for high risk myeloma, we do have some data to say that, tandem is there, but the data is not as impressive. So I think an autologous transplant at first is something I would go with. Tandem with the increased risk of mortality, and in an era of bispecifics where we are talking about MRD negativity already, I don't think tandem is going to have a role anymore. Because now initially, if I have 2 minutes, can I say, sir, initially we were thinking the MRD negativity brought about by melphalan based conditioning followed by, autologous stem cell. had a way deeper MRD response. But we have upcoming data that it is not so. We have seen the MIDAS trial data. So it is still maturing. I think MRD negativity is going to be the same whether it's BITE or CART or it's going to be transplant. So I think tandem transplant will lose its role. If he is MRD negativity, how sustained MRD negative the patient is going to be is what we are going to be. After Daratecli, I will transplant the patient, not tandem transplant as of now.
Oh, thank you.
The time is up. I'm going to ask my last question.
Yes, sir.
Hypothetical question. Your some guess. What's going to make autologous transplant obsolete?
So I think it is going to be obsolete in the near.
What's going to make it obsolete? What will
The
be
CARs,
the you will offer
the immunotherapies, the T cell redirecting therapies are going to make it.
as first line?
Yes.
CAR-T used in first line will make autologous transplant obsolete.
It. I'm hoping it will, and the trend is towards. Finance is not a bar. So whenever you ask me a question, I always assume that finances are not a bar. So I think yes, it is going to be.
Okay. Thank you so much, Dr. Fahima, for this
Thank you,
wonderful
sir.
QA
Thank you.
session. After
Thanks a lot, sir. I'm grateful for the opportunity.
Sir, I have just a comment to this thing. Sir, we have a case report of a 17-year-old male girl of multiple myeloma.
Dr. Babita, I won't be able to discuss a case now. Our next speaker is already
We won't discuss, but just we have case report of a 17-year-old.
You write to her in the chat box because it is 7:31 and I don't want my next speaker.
Okay, right, sir.
Thank you so much. I'm sorry for that.
Thank you, everyone. Thank you.
Thank you. So I'll just share my screen to introduce our next speaker. We have Dr. Deepanjan Haldar from UK. So Dr. Deepanjan Haldar, about a year ago, I would have introduced him in a very different way. He was right here in Mumbai, but now he is international senior portfolio doctor, specialist grade hematologist at Withybush General Hospital, NHS Wales in UK. He is a dedicated hematologist currently working at Withybush General Hospital in Wales. He began his NHS career on 1st April 2025, bringing with him a decade of experience as a consultant in Mumbai, India. He is a DM Clinical Hematology Gold Medalist, reflecting his academic excellence and strong foundation in the specialty. Before moving to UK, he worked extensively in clinical hematology and hemato-oncology and played a pivotal role in setting up the BMT units across different groups of hospitals in Mumbai. He also completed a fellowship in leukemia bone marrow transplant from Vancouver, British Columbia, further strengthening his specialization in complex blood disorders. His research interests include endocrinopathies in thalassemia, hematological changes in Kala-Azar, critical care hematology, and hematology medical workforce planning and well-being in Wales. He is a life member of Mumbai Hematology Group, Indian Society of Hematology and Blood Transfusion, and the British Society of Hematology. He is committed to delivering high-quality patient-centered care while contributing actively to academic and professional development in hematology. And today he's going to tell us all about ETP, acute lymphoblastic leukemia. I'll stop here and request Dr. Haldar to share the platform.
Thank you, sir, for giving me this opportunity. It is always a pleasure. Good evening, everyone. I'm just going to share my slides now. Are my slides visible in full screen mode?
Yes.
Thank you. Thank you, sir. So I'll be speaking about early T precursor ALL, and I have named it as case, consensus, and controversies. That's the order in which I'll be presenting. So I'll be presenting 3 cases to just give you a brief overview how heterogeneous ETP ALL can be. So this the first patient of ETP ALL was a 27-year-old patient whom I saw in Vancouver in April 2017. He was quite well prior to presenting to us. Just 1 week history of feeling generally unwell, painful sore throat. Examination wise, just small amounts of bruising over his lower limbs, gum bleeding, and an episode of epistaxis. No history of any fever or chill. no history of any visual symptoms or any other neurological symptoms. Some previous wrist injury from a fall 3 months ago. Examination-wise, he was stable, afebrile, and had significant erythema over the soft and hard palate and small lymph nodes palpable in the cervical region. His blood count showed very high white blood cell count along with blast count of 225 and severely elevated LDH. But apart from that, his biochemistry parameters were quite well preserved. The aspirate and biopsy confirmed showed markedly increased cellularity along due to infiltration by blasts. There are mitotic figures prominent in the biopsy. The flow cytometry showed was consistent with a T cell origin, with bright CD7, partial CD5, dim cytoplasmic CD3, negative for CD2, 4, 8, and surface CD3. And in addition, there was aberrant expression of CD117 and partial CD33. The immunohistochemistry wise, the blasts were CD3 negative to dim positive, and roughly 1/4 had strong TDT expression. MPO was completely negative, and there was uniform positivity for CD99 and variable positivity for CD5. Karyotyping showed 7 metaphases, and FISH analysis showed no evidence of BCR-ABL or MLL translocation. The T cell clonality, the multiplex PCR was positive for a T cell clone. So diagnostic comment was cytoplasmic CD3 was variably positive. The overall phenotype was most suggestive of early T precursor ALL, and which often shows aberrant expression of myeloid markers and is associated with a poor prognosis. So subsequently in Vancouver, this patient was started with ALL 1301 protocol, and his CSF was positive, so he was on twice weekly intrathecal chemo as well. However, the day 15 marrow, it showed the blood, bone marrow, aspirate, and biopsy findings were still showed features of persistent acute leukemia with cellularity of 90% and blast of 95%. It was almost like as if this patient had received placebo treatment without getting any actual chemotherapy.
Hello, sir. Sorry
Yeah.
to interrupt.
Yeah, please.
Can we do the single screen without the next animation slide visible?
Okay, I'll just try doing it. Is it sharing in the full screen now?
No.
No, sir. It just
Okay.
only the, if you can press on the, yep, presentation view. No, it's not happening.
I'll stop sharing and try sharing again, if that's
Sure,
okay.
sir. Perfect, sir.
Is it fine now?
Yep. Yes, sir.
Okay, excellent. So subsequently, he was started on etoposide cyclophosphamide salvage, and which he tolerated well, and the CSF eventually cleared after 6 settings. But so
Not moving, is it?
No, it's not moving now. Is it moving now?
Yeah.
Yeah. So, So the marrow post etoposide cyclophosphamide salvage chemo still showed 50% cellularity and 15% blasts, and this was still consistent with persistent disease. So generally in Vancouver, we are allowed to use 2 lines of treatment in a newly diagnosed ALL, but this patient, quite young, fit patient, so was discussed in the outpatient rounds. After 2 rounds of chemo, he still had persistent disease, so he was put on Hydac salvage as the 3rd round of chemo. Post Hydac salvage, the chemotherapy still the bone marrow showed 50% cellularity and around 10% blast, which was still consistent with persistent disease. So moving on, this patient was then started on 4th line of upfront chemotherapy with nelarabine. Mind you that this I'm talking is of 2017. So after nelarabine, again, the blast count was 86% and with cellularity of 90%. So compared to the previous biopsy, which showed 20% cellularity and 10% blast, the blast as well as cellularity had increased in the current biopsy. So basically, this patient was had a refractory disease despite 4 rounds of quite strong and intensive chemotherapy. And he was thereafter referred to best supportive care because, there was really no other option available back then in 2017. Moving on to the next patient that I treated in Mumbai. So young patient, 21-year-old patient, almost the same age group. So again, diagnosis of early T precursor ALL based on the flow cytometry report. So this patient, MRD was positive on day 33 at 0.8%, negative on day 64. The patient did not have any matched sibling donor, and there were financial issues, and the patient was not willing for either MUD or haplotransplant. So after treating with pediatric inspired BFM protocol, we basically had to put the patient on maintenance, and the patient just did fine on oral 6-MP and methotrexate maintenance. This was the second patient. This is the third patient of ETP ALL that again I treated in Mumbai. So again, a young female, 29-year-old lady. So her diagnosis was ETP ALL, day 33 MRD was positive, day 64 MRD negative. She had a matched sibling donor, so she underwent matched sibling donor allogenic stem cell transplant, and she is presently doing fine after like bone marrow transplant. So basically, I showed 3 patients of ETP ALL. One patient, the first patient that I talked about, had extremely refractory disease who did not respond to 4 lines of upfront chemo. Second patient did fine just with standard chemo. And the third patient did fine after allogenic bone marrow transplant. So ETP ALL, it indeed is an interesting disease. It was listed as a provisional entity in the earlier classification. But in the latest WHO classification, it is listed as a definitive entity, early T precursor lymphoma leukemia. So thus further talk I'll be covering under the following headings. I'll be briefly speaking about background, epidemiology, clinical features, diagnosis, biology of ETP ALL, treatment, and covering briefly about the prognosis. So starting with the background, we are all familiar with this classical scheme of hematopoiesis, in which we see there is an early bifurcation into the lymphoid and myeloid branches. So the hematopoietic stem cell or the progenitor cell, they bifurcate into common lymphoid progenitor and the common myeloid progenitor, and subsequently into pro-T, T, pro-B, and B cells. But the problem with this is the existence of progenitor possessing T and myeloid potential within the thymus is incompatible with the, this dichotomy model of hematopoiesis. So because there are, so in this model won't explain why the T cells or the early T precursor cells can have myeloid markers. So we now know that adult T cell progenitors retain myeloid potential. So the dichotomy model would be incompatible with that that observation. So now we have got this model of hematopoiesis, which is called as the myeloid-based model of hematopoiesis, which is applicable to both fetal and adult hematopoiesis, in which we have got these hematopoietic stem cells. They differentiate into B cells, and then there is shut off of the B cell potential, and it gives further rise to macrophage T progenitors. So from there, we get the T cells, NK cell, dendritic cells, macrophages. So basically, this can still explain why early T precursor cells can have the myeloid markers. So we have moved on from this classical scheme of hematopoiesis to this revised scheme of hematopoiesis in which the B cell differentiation takes early, and then we have the myeloid and the T cell differentiation taking place as a separate branch. So early T precursor ALL, it was kind of the early studies were done in and around 2009, and were published in Lancet Oncology. First reported by Koston Smith et al. The clinical features were often regarded as unreliable predictors of outcome in TALL patients treated with intensive therapy. And he basically hypothesized that TLL originating from early T precursor would respond poorly to lymphoid cell-directed therapy. So in his study, basically, he showed that the characterization of ETP ALL, when he compared ETP ALL with standard T cell ALL, be it in the day 15 MRD or the day 43 MRD when these patients were treated as per St. Jude's protocol, or early MRD day 33 in the AIOP protocol and day 78 MRD. So the early T precursor ALL patients, they definitely were more significantly MRD positive than the normal TALL patients, be it in day 15, day 43, day 33, or day 78. So prevalence of MRD during the early phase of therapy for patients with ETP-ALL, so this was definitely, the MRD was more prevalent in this patient. So in addition, those patients who were MRD positive in the ETP-ALL versus the standard TALL, the ETP-ALL patients had a worse prognosis than compared to the typical TALL patients. So for example, the 2-year estimates for the AIEOP patients who had MRD positive on day 78 were 69% for the ETP-ALL patient versus the 32% with the typical TALL patients. Similarly, for prednisolone response as well, the ETP-ALL patients had the more number of patients had prednisolone poor response as compared to the standard TALL patients. So summarizing from these early studies, the overall survival, the event-free survival, the remission failure, all these things were much poorer in the ETP-ALL patients as compared to the standard TALL patients. Similarly, the cumulative incidence of relapse, the probability of relapse. So all these were poorer in the ETP-ALL patients as compared to the standard T-cell ALL patients. In fact, on the univariate as well as multivariate analysis, the patients being ETP-ALL was the most important factor prognostically, be it on univariate as well as multivariate analysis when we are talking about overall T-cell ALL prognosis. So I've seen into the background studies. Now moving on to the epidemiology of ETP-ALL. So initially it was described from the pediatric cohorts. The frequency of ETP-ALL in these studies range from about 10 to 15%. Based on gene expression analysis, there is something called as near ETP as well, which we will understand subsequently, which has been shown to be slightly more prevalent than the classical ETP-ALLs. Again, epidemiology-wise, it is slightly more in older kids. If you recollect the 3 patients that I had shown, so all of them were in their 20s. Less commonly, this ETP-ALL is associated with mediastinal mass as compared to standard TLL. So in which mediastinal mass is seen in about half of the patients. In ETP-ALL, it is seen in just about quarter of the patients. Diagnosis, as I've already mentioned, so there is lack of CD1A and CD8 expression. There is weak CD5 expression and expression of one or more of the following myeloid or stem cell antigens in at least 25% of the leukemic cells. That is CD117, CD34, HLA-DR, 13, 33, 11B, and or 65. So these have to be expressed in at least 25% of the leukemic cells. So again, there is mandatory criteria. So that is CD1A and CD8 negative, surface CD3 is negative. The TCR gene rearrangement is negative. CD5 is negative in or a dim positive in less than 75% of the blast, and presence of one or more stem cell or myeloid antigens. And positivity of these markers do not exclude the diagnosis of ETP ALL. So these markers may be variably positive, and their positivity does not exclude the diagnosis of ETP ALL. So moving on to the biology of ETP ALL. So there are various genetic aberrations seen in ETP ALL. As we have already seen, the ETP ALL derived its genetic profile from the earliest thymic progenitor cells rather than the common lymphoid progenitor, which usually lose the B cell differentiation potential. And therefore, they maintain their myeloid and T differentiation potential. So often these genetic the genes that we see are similar to that ones that were generally mutated in the myeloid neoplasms, because their cellular origins and genetic profiles therefore resemble those of the myeloid progenitor cells. So these are the genes that are commonly mutated: the FLT3, JAK, interleukin 7 receptor, the RAS pathway genes. There are various epigenetic pathway modifiers, transcription factors which are mutated, and there are certain genetic rearrangements that take place as well, of which the most important is probably this gene, the PRC2 gene. So this is generally mutated early in the ETP ALL. So there is this genetic inactivation, and the genetic inactivation of the PRC2 gene, this leads to loss of this gene H3K27ME3 loss. Now what happens as a result of this is there is increased transcription of these various oncogenetic factors. So this is basically a silencing gene. Now, inactivation of the PRC2 leads to this genetic loss of this gene, H3K27ME3. And once this is lost, this leads to subsequent increased transcription of the various downstream oncogenetic pathways. And this is thought to be resulting into the subsequent generation of the ETP ALL. In addition, as I mentioned, the interleukin 7 receptor mutation seems to be initiate early T precursor leukemia in the murine models. This is important because this is used therapeutically because ruxolitinib is used in the ETP ALL model, which we'll see subsequently. Now, comparing the mutation analysis in the ETP ALL versus standard TALL, so we see that ETP versus non-ETP. Then the Notch1 genes, they are much more significantly mutated in the non-ETP cases than in the ETP ALL patients. On the other hand, FLT3, WT1, so these are mutated more commonly in the, FLT3 is mutated much more commonly in the ETP ALL, and WT1 is mutated much more in the non-ETP ALL. So basically, a high rate of FLT3 mutations was seen in the ETP ALL. And thus, with respect to these genes, it would suffice to say that there is clearly a different mutational profile in the ETP ALL as compared to the non-ETP ALL. So again, just to show, in the non-ETP subgroup, we see that the Notch mutations are the commonest one. But in the ETP ALL subgroup, we see that the FLT3 mutations, they are quite much more significantly common as compared to the non-ETP subgroup. So now moving into the most important part of the presentation, which is therapeutic strategies. So what should be the approach to, and I'll be covering this under the following headings: approach to treatment, induction, why should we be using a pediatric based protocol, significance of MRD, post-induction strategy, whether all the patients of ETP ALL, even if they're MRD negative, should they be undergoing a bone marrow transplant in first remission? Approach to relapse or refractory disease, nelarabine, various targeted inhibitors, gamma secretase inhibitors, JAK inhibitors, FLT3 inhibitors, venetoclax, PIM protein kinase inhibition. So we'll be looking into various of these pathways subsequently. So this is standard approach to T-cell ALL. Whenever we have got a new patient with diagnosed T-cell ALL, we first try to see whether this patient is fit for pediatric intensive chemotherapy. So if this patient is fit for pediatric intensive chemotherapy, generally we go ahead with pediatric intensive regime. But however, if the patient is not, we could either because of older age or subsequent comorbidities, we could go ahead with conventional multi-agent therapy. And then subsequently, generally, if the patient is MRD negative, no adverse genetics. What we mean by no adverse genetics? This is basically no Notch1, FBXW7 mutation or presence of NRAS, KRAS mutation, or PTEN gene alteration. So that would qualify as adverse genetics. So if the patient is MRD negative and no adverse genetics, generally we go in with standard chemo consolidation maintenance therapy. If either MRD is positive or there are adverse cytogenetics, generally the patient is transplanted. However, if the patient is not achieving CR, we could look into the nelarabine or various other salvage options, which I'll be dealing subsequently. So why should we use pediatric-based regime in the treatment of TALL patients? So again, this is quite well documented now. So published in Leukemia Lymphoma well back in 2017. So compared to the at median follow-up of about 3 years, 3-year event-free survival was significantly increased in patients on pediatric protocol versus adult protocol. And there was a significant trend towards improvement of overall survival as well. So therefore, if the patient is young and fit, we always try to treat these patients with pediatric-inspired regimen. Now, the next question is post-induction strategy, whether all these patients should be undergoing bone marrow transplant. So what are the standard recommendations for post-induction strategy in TALL patients? So these are the patients who should be undergoing allo-HSCT in first remission. So as we see, early T precursor is mentioned as one of the standard indications for upfront allo-HSCT in CR1. But with the caveat that MRD negativity may override these unfavorable prognostic factors. So this is not very clear if the patient is MRD negative after achieving CR1, whether we should routinely transplanting all of these patients or not. And we'll be subsequently seeing this in the slides. So now, the role of transplant, so clinical significance of early T precursor ALL in the children's cancer study group. So in this study, basically 91 patients with T-cell ALL and there were just 5 ETP ALL patients. So 4 out of 5 patients, they relapsed after the conventional chemo and underwent stem cell transplant subsequently, of which 3 were alive after significant follow-up period after allo-HSCT. And therefore, from this study, they concluded that it suggested that allo-HSCT should be considered as a frontline therapy for ETP ALL patients in first remission. So these are certain studies which have shown that with the limitation of potential bias for patients undergoing allo-HSCT, it was observed for ETP ALL patients undergoing allo-HSCT had a favorable outcome with 3-year overall survival of 74%, compared to those patients who did not undergo allo-HSCT but were treated with chemotherapy alone. Their overall survival was just about 37%, so quite significant difference. So these are certain studies which say that ETP ALL patients, even if they are MRD negative, they should be undergoing allo-HSCT in CR1. So again, just to show that with allo-HSCT, the prognosis of the ETP ALL patients significantly improve as compared to those patients who are not undergoing allo-HSCT in CR1. Moving on, there are certain studies which do not agree with allo-HSCT in CR1 as well. So for example, this was a phase 3 study for patients with TALL. This was basically standard 4-drug induction followed by response-based risk MRD detection by flow cytometry at day 29. And those patients who were intermediate and high risk, they were randomized to receive or not receive 6 5-day courses of nelarabine during consolidation. So children's oncology group study group protocol basically. So those patients who were positive for MRD, some of these patients were randomized to receive nelarabine in multiple phases: consolidation, delayed intensification, and maintenance as well. So their study basically quite large study, 1144 children with TALL and ETP ALL, more than 100 patients. So to summarize the findings, all the 3 immunophenotypic groups showed excellent 5-year EFS and OS that were not significantly different in the ETP subgroup, near ETP or not ETP. So this was the largest study of TALL ever conducted and showed excellent outcomes for TALL. In particular, ETP was found to have outcome identical to non-ETP patients. However, we have to keep in mind that many of these patients, they had received nelarabine in multiple phases of their treatment. So that could be accounting for the improved outcome seen in this study. Again, this is a multi-center meta-analysis of effect of T-cell leukemia subtype and MRD on allogenic stem cell transplantation outcome. So to summarize, there was no difference in OS, PFS or cumulative incidence of progression between disease subtypes, including ETP patients. And ETP patients transplanted in CR1 had overall survival at 47%, which was comparable to other disease subtypes. So basically suggesting again that allo-HSCT can overcome the poor prognosis associated with ETP. So it is still out to the jury whether all ETP patients should be undergoing transplant upfront in CR1. But yeah, as I showed you, even in the 3 patients that I discussed, that one of the patient is still doing quite fine with just oral chemotherapy as maintenance. So what is probably more appropriate now is for the patients to have risk-adapted therapy. So we have already seen what is ETP. And then there is something called as near ETP. So why it is important? Because many of these studies which show different kind of outcomes with ETP-ALL, some of these studies have included the near ETP group in the within the ETP cohort, and which could account for slightly different outcomes reported across the literature. The near ETP is basically negative for CD1A and CD8, and they're positive for myeloid or stem cell markers. But the key difference being CD5 expression is higher than the classical ETP subgroup. And not ETP, of course, is the one that meets the standard T cell diagnostic criteria. So I've seen about significance of MRD, the post-induction strategy, or whether the patient should be undergoing allo-HSCT or not. Now, let us move on to the relapsed or refractory disease subgroup, because we encounter that quite often in the ETP subgroup of patients. So nelarabine, we all are familiar with this drug. The phase 2 study in relapsed T-cell ALL had shown 41% response rate with 31% patients achieving CR. Importantly, 80% of these patients could proceed to allo-HSCT. The 1-year survival was 28% and 31% for patients being taken up for allo-HSCT. So in refractory T-cell leukemias, nelarabine combined with etoposide cyclophosphamide. So this was thought to be one of the salvage regimens. So all patients had shown some response to the combination therapy, and 5 of the 7 went into complete response, and one after 1 or 2 cycles of this chemotherapy, and they think that this could be one of the potential chemo-based combination. But this are like studies back like about a decade back. So people have also used nelarabine upfront. Nelarabine hyper-CVAD updated data revealed quite decent outcome, with the 5-year OS being 83% with nelarabine compared to 38% without nelarabine in cohort of non-ETP ALL. And ongoing trial amendments. I'll be showing this data. These are quite encouraging. They have combined venetoclax as well as peg asparaginase as well. And the UKLL14, the 5-year DFS rates for patients with TLL randomly assigned to nelarabine and no nelarabine was 88% versus 82%. So really not very significant, but still some improved outcome in the UKLL14 cohort as well. So the MD Anderson group has really described quite dramatic outcomes in their TLL cohort population. So the study is called as ALL748 study. So quite an interesting study actually, in which they have added venetoclax to hyper-CVAD nelarabine and pegylated asparaginase backbone. So it shows quite improved outcome in the patients of T cell ALL in general and ETP ALL as well. So in patients with ETP ALL, the 2-year duration of response and overall survival in the venetoclax cohort, so the venetoclax in combination with hyper-CVAD nelarabine and pegylated asparaginase, the 2-year duration of remission and overall survival was 100% compared to 55.6% and 47% in the original cohort, despite comparable rates of allo-HSCT. So these regimens are well tolerated with no serious CNS neurotoxicity, and attributed to study treatment despite all cohorts receiving nelarabine. So this is definitely quite encouraging data, especially when we are talking about ETP-ALL, which historically had quite poor outcome. People have also tried AML kind of treatment for ETP-ALL as well. I mean, theoretically it does make sense. So just paper from last year. So venetoclax in combination with hypomethylating agents are effective salvage therapy in relapsed refractory ETP-ALL and near ETP-ALL. The overall response was 71%, which is quite encouraging in this refractory group of patients. And notably, all 6 patients treated in second line responded, and undetectable MRD was achieved in 5 out of the 8 evaluable patients. So biologically, it does make sense because the cell of origin is similar. The ETP ALLs do express myeloid markers. So this is also quite encouraging data of aza-ven in ETP ALL. JAK pathway inhibitors. So I've shown previously that the interleukin-7 receptor mutations are there in the ETP-ALL. So people have tried ruxolitinib as well in ETP-ALL. So the JAK inhibitor demonstrated robust activity in patients, but these are generally murine models. and the outcome was seen, and the preferred outcome was seen even in patients independent, even in where the JAK-STAT pathway mutations were not there, raising possibility that the therapeutic potential of ruxolitinib in ETP-ALL extends beyond those cases with JAK mutations as well. So the therapeutic benefit was seen even in where the JAK-STAT pathway was not mutated. So FLT3 mutations, we have seen that FLT3 mutations are present in ETP-ALL. So therefore, the FLT3 inhibitors, they could be tried in ETP-ALL as well, and they have been tried in studies and with encouraging response rates as well, of almost about crossing 70%. So in addition, PIM protein kinases are mutated in ETP-ALL as well. So people have tried ponatinib, a broadly active tyrosine kinase inhibitor. So this resulted in synergistic T-cell ALL growth inhibition and marked apoptotic cell death. So all these are mostly kind of experimental studies. But yeah, the MD Anderson study and the AZAVEN study, they are quite encouraging. And this is just to show in the cell lines that when ponatinib was added, the ETP-ALL cell lines, they had significant inhibition of the growth. What about daratumumab? So daratumumab has been tried in ETP-ALL as well. So CD38 expression by flow cytometry was seen in 21 patients with TLL, both in early T precursor as well as in non-ETP-ALL. And this basically these were tested in the murine models, and it is basically in the early phase trial for children as well as in young adults with relapsed refractory T-cell ALL. So again, triplet therapy, daratumumab combination with venetoclax and bortezomib. So there have been studies in primary resistant TLL, dara, ven, and bortezomib. So the overall the early results have been encouraging. So to summarize, whatever novel therapies we have seen in ETP-ALL, so we have seen that the results with venetoclax has been quite encouraging in the MD Anderson cohort, wherein they have combined venetoclax with nelarabine, hypercvad, and pegylated L-asparginase. We have seen there are some early studies about ruxolitinib, FLT3 inhibitors, anti-CD123 because it's quite prevalent in ETP-ALL. There are some potential CAR T cell studies as well, which are mainly in phase 1. Targeting CD5 and CD7. So we have completed about the therapeutic strategies in ETP-ALL. My last section of today's talk will be about prognosis. So just to briefly summarize, as I've shown in my 3 cases that I showed initially, that the prognosis of ETP-ALL is quite heterogeneous. The first patient that I presented failed 4 lines of upfront chemotherapy. Second patient did fine just on chemo, and the third patient did fine after allogenic matched sibling donor BMT. So the prognosis, when we look into the literature, the prognosis of ETP-ALL in general, it's quite poor. But then there are some studies which have reported quite good outcomes as well, with event-free survival of 87% and OS of 90%. But most of the studies, they have reported quite poor outcomes. Now, what is the cause of such heterogeneity when we are talking about ETP-ALL? This could be because different prognosis, could be because of different classification systems. So as I mentioned that the classification is not straightforward. For example, in the 69% of the patients in the UK-ALL ETP-ALL cohort, which reported good outcomes for ETP-ALL, they're actually subsequently classified as probable ETP-ALL or near ETP-ALL. So the actual number of definitive ETP-ALL patients were quite small. So as I mentioned that often patients who are probable ETP or near ETP, some of the studies do include them in their ETP-ALL cohort. And that could account why some of the studies are reporting good outcomes and some others quite inferior outcomes. The different outcomes could be resultant from different treatment approaches as well. For example, we saw that the Children's Oncology Study Group, they have, based on the MRD, they have randomized patients to receive nelarabine in various phases of treatment, consolidation, delayed intensification, and maintenance. And naturally, this study group, they had shown that the transplant is not needed in this cohort of patients. But that could be because they're using nelarabine much more frequently than various other study groups. The difference in outcomes between various cohorts, it could be because of the genetic heterogeneity as well. So when we talk of ETP-ALL, we talk of it as a single disease entity. But as you can see from the gene mapping, that different the genetic heterogeneity is quite significant in ETP-ALL subgroup of patients as such. So one of these genes that has been identified to be of poor prognosis is HOX-A gene. So studies have shown that the presence of the ETP-ALL patients who have got this HOX-A gene mutation positive, only they are the ones that have got poorer outcome, versus those that are HOX-A gene negative. They have got similar outcome to the other T cell ALL patients. So striking the presence of an early thymic precursor like immunophenotype is associated with marked outcome differences within the HOX-A positive group. The 5-year overall survival in the HOX-A positive group was 31.2% versus 66% in the HOX-A positive non-ETP group, but not in HOX-A negative group of patients. So basically, if we have got ETP-ALL but the HOX-A gene is negative, then the outcome is not bad, 74% overall survival versus 31% if the HOX-A gene is mutated. So the negative prognosis of the ETP-ALL could be exclusive to the HOX-A positive group of patients only. So with this, I move into my final slides, basically. So take-home messages. So ETP-ALL definitely is a distinct pathobiologic entity. It accounts for 10 to 15% of the total T cell ALL. The immunophenotyping is characterized by lack of CD1A and CD8, weak CD5 expression, and expression of one or more myeloid or stem cell antigens. The myeloid-associated gene mutations are much more common in ETP-ALL, such as FLT3, NRAS, KRAS mutations. They are reported at much in higher frequency in ETP-ALL, whereas more typical TALL-associated mutations, such as Notch1, they are quite infrequent. Most of the studies report a dismal prognosis of ETP-ALL, but we have got light at the end of the tunnel, especially with the recent MD Anderson study. Role of alloSAT in CR1 and target therapy for refractory cases needs to be considered. And as I've shown that there are various molecules in the pipeline, ruxolitinib, nelarabine for quite some time, venetoclax now, azaven combination. So there are different molecules down the pipeline which could improve the prognosis in this subgroup of patients. With that, I would like to conclude, and I'd be happy to take up any questions. Once again, my gratitude to Mumbai Hematology Group and especially MB Agarwal sir for giving me this opportunity.
Thank you so much, Dipanjan. Enjoyed a complete talk, updated us. So would you say that there will be an addition of any one of the targeted agent or nelarabine upfront in all patients of ETP ALL, or you'll keep your induction protocol just like any other T cell ALL?
Sir, I am very much encouraged by the MD Anderson group study. So in which they have added venetoclax to the nelarabine hypercivat pegylated asparaginase based protocol, because some of these, like the ETP-ALL patients, so some of them have got like completely refractory disease, as I had shown the first patient I had shown. So 27-year-old chap, but they really did not respond to very intensive frontline treatments. But yeah, so venetoclax probably is definitely, I believe, is definitely worth exploring in this subgroup of patients.
So both nelarabine and venetoclax, you would say, should become a norm for ETP ALL.
Yes, sir. So I do not know whether there have been just studies seeing just venetoclax in combination with hypercivat and pegylated asparaginase without the nelarabine. But that would be probably some interesting to explore, because in the cohort that MD Anderson group, we do not know how much of the benefit was because of the venetoclax and how much of it was because of nelarabine. But that probably could be an interesting idea to explore as well. But after the addition of venetoclax, the outcome improved to 100% in quite a significant subgroup of patients.
Right. And would you say that pediatric protocol using PEG-L asparaginase almost mandatory for this group of patient, or you can use hypercivat?
Sir, I would definitely agree that pediatric-based protocol should be the norm for these patients, incorporating pegylated L-aspergillus, especially for patients up to 40 or 45 years of age, whom we believe can tolerate this regime. Beyond that, it becomes a bit tricky to give pegylated aspergillus because of the side effects. But yeah, those patients who are fit and young without significant comorbidities should definitely be treated with a pediatric-inspired protocol.
Any comment on DEXA versus prednisolone in such patients?
Uh, Not actually, sir, because I know different protocols use different steroids. The BFM pediatric protocol generally uses prednisolone-based induction. The hypersevere generally is like DEXA-based. So, yeah, not very significant outcomes in those subgroup. Either DEXA or prednisolone should be fine.
Your choice of upfront transplant will be based on MRD or will be based on the baseline genetics, the NGS panel, or you'll do it uniformly for everybody?
So I would be keen to do transplant in ETP ALL patients upfront for all patients, provided if matched sibling donor is there. Uh, and of course, cost is not an issue, but so the genetics for T cell ALL, such like HOXA gene, these kind of genes are not routinely looked into the genetic panels that we are sending. So probably an ETPLL by risk stratification falls into the high risk T cell ALL risk group. So I'd probably transplant all the patients if they have got a matched sibling donor, irrespective of the MRD status. It becomes a bit more tricky if there is no matched sibling donor. So, for example, one patient I showed, the second patient basically, so did fine just without a transplant. So, and ETPLL patients generally the MRD is much more frequently positive in the early phase. So, day 33 MRD is positive in almost all the ETPLL patients. 70-80% of them will be day 33 MRD positive. So it is the later MRD, the day 64 or the day 78 MRD, which becomes more important in prognosticating this group of patients.
And what will be your dose of high dose MTX in these patients, just like any other T cell ALL or?
Any other T cell ALL, sir, there is no difference in the dosing of the high dose methotrexate like the dose. So as for any other T cell ALL.
And the near ETP and ETP, it will be same approach?
So not actually, sir. As I had shown, the near ETP ALL subgroup, generally they tend to behave more favorably and their outcome is more in keeping with the non-ETP subgroup. So the problem happens is because many of these near ETP subgroup, they sometimes get classified into the ETP subgroup if we are not interpreting the immunophenotyping very closely. So, and then that could kind of, even in studies, so the UKLL study as well, so they can yeah, the prognostic implications generally then get barred. But the I would treat the near ETP subgroup more in keeping with the T cell ALL rather than ETP.
And if a patient is refractory, like one of your patient was also, or if a patient relapses, would you say that AML-like protocol FLAG-IDA will be the best option?
Yes, sir. Either FLAG-IDA or I'd be more keen to probably explore even AZA-VEN. So, because now there are quite a good number of studies which have shown that venetoclax has got quite an effect on this subgroup of patients. So, for example, I had shown by one study they have just used AZA plus VEN, and with that nearly second line everybody responded, and almost like 80% of them became MRD negative. So, yeah, of course, we did not have this kind of approach when we treated the first patient in 2017. And yeah, we had lost him, unfortunately, so nobody thought of Azaven at that point of time.
Any role of bortezomib?
Yes, sir. So daratumumab, bortezomib, and venetoclax. So triplet combination therapy. So there are studies in refractory T cell ALL and especially in ETPLL subgroup of patients where this combination has also shown good outcome.
Dr. Shweta has a question. Any experience of using Azaven in 4-year-old relapse refractory ETP ALL?
Dr. Shweta, I'm afraid I do not have any personal experience. we could definitely look into the Chinese paper that I've mentioned. I think it's published in Blood. So, and I'll be happy to share the link with you. So, yeah, so in which they had given azaben, but if I recollect correctly, that was mostly in the adult subgroup of patients.
Thank you. The other question is from Aishwarya Raj. Is it mandatory to do the NGS panel in a clear-cut case of ETP ALL based on immunophenotyping? And if you do that NGS, what is its effect on deciding the treatment strategy?
So yes, NGS should be done in all ALL patients. I'm not sure whether it is being routinely done now, but it should be done because it becomes quite important in choosing the treatment for the refractory group of patients. For example, FLT3 mutations, NRAS mutations. So these kind of mutations, there are certain mutations which you can target. So if possible, the NGS should be done.
Dr. Anil Kumar wants to know any correlation between deletion 5q with the ETP?
Not that I'm aware of. So yeah, individual genetic chromosomal prognostic, I cannot recollect offhand, but I'm not aware of any particular implication.
Such a rare thing that there can't be data really. Another question he has asked is about TLX3 allele in ETP ALL. I think the same answer. It is all rare things, so you can't have any data on these things. Dr. Babita, your question.
Hello, Dr. Babita.
Well, thanks for the wonderful talk. That beautifully shown 3 cases, and what we have understood from those cases is that with the variable positivity for the T cell markers 1, secondly, considerable positivity for the myeloid cell markers, and genetic wise also mutations also, as you have shown, in favor of the myeloid lineage. It more like mimics ETP AL, mimics the AML. So this my query is that what is there any WHO cutoff percentage for the blast percentage, sir? As it in the AML it is more than 20%. As you have shown in first case that the more than 20% blast initially and then the 86% of the blast, or the any number of the blast percentage can be, we can label it as ETP ALL, sir. What is your comment, sir?
Yeah, so the standard criteria for ALL will apply only that CD5 expression. So there the cutoff is 75%, less than 75% in the ETP subgroup. Less than
presence of
75% of the blast should be expressing CD5. In the ETP, in the near ETP, it is more commonly expressing CD5. So that is the only difference. But apart from that, there is no separate cutoff. So the standard cutoff for ALL will apply.
So at least the 75% blast should be there to.
No.
This is our.
Babita, don't get confused. First, you diagnose your acute leukemia based on your more than 20% blast. And then the immunophenotyping will tell you whether it is a ETP ALL or classical T cell ALL.
Yeah. So the
75% business comes there. Not
so
for
the 75% is for the CD5 expression that I'm talking about. The standard criteria for leukemia, which is 20%, of course, applies to ETP as well. So CD5 expression less than 75% in the leukemic blast. So that is for ETP-ALL. In the near ETP, the CD5 expression will be higher.
Of the total 20% blast, which is the.
So that will apply for all the patients, yes.
20%. Okay. Yeah. Thank you.
Thank you. There are no more questions in the chat box. There is no raise hand sign. Anybody wants to ask anything else to? None. So we have a couple of minutes. You want to give, Amit, you want to ask?
Wonderful talk, Dipanjan.
Hi, Amit. Thank you.
I'm getting you online. So pleasure to meet you again.
Yeah, always pleasure to catch up with Mumbai Hematology Group, and it's very wonderful to meet everybody online. Seeing sir as well after more than a year now. So yeah, and yeah, I do keep getting the mails and makes me miss Mumbai Hematology Group very much. But yeah, so always a pleasure to catch up with everyone online.
So January we have our 50th Golden Jubilee anniversary of MHG. So I'll send you the dates. please see to it that you can come.
Absolutely, sir. It will be a pleasure.
Guest faculty. The dates are
Absolutely.
15th to 17th January next year.
Yes, sir. I still continue to be a life member of Mumbai Hematology Group, which I will absolutely cherish.
Of course, yes. Yeah, so I think that's the end of it. So do we have in task to give the vote of thanks? Otherwise, I will do the job. All right, so grateful to both for their wonderful lectures. Grateful to all the discussants here, the audience, our sponsors, and the event manager. So we meet on next Thursday again at 6:30. Good night for everybody.
Thank you, sir. Good night.
Bye-bye.